great to be here with you today, and it's my honor and privilege to provide you with a panoramic view of healthcare and being a person with health problems, and how decision-making fits into that. I'll have a flow of the presentation. We'll start with a person, Amy, who was here at this conference last year, and then we'll talk a little bit about measuring value in healthcare, and then cone in to focus on shared decision-making within healthcare and measurement thereof, and a few final points. So, Amy, about 8 years ago or so, Amy moved to Pomfret, Vermont. She came here alone. She was a special ed teacher, and she was getting off to a great start in the elementary school there. And around Halloween, she was doing self-care, breast self-exam, and noticed a lump. She made an appointment at the Comprehensive Care Center, Comprehensive Breast Care Center at Dartmouth Hitchcock, that Dale Collins-Vidal was the director of. And behind the scenes, Dale and I had thought it would be really great to track a person's experience in coming into the comprehensive breast program and understanding that experience from her own point of view. So Leslie Lamb, a quality fellow with us, was with Amy every time she visited Dartmouth for her care for 6 months. And this is a snapshot of Amy's journey. She had about 21 different visits to 16 different clinical microsystems, smaller units that are providing care in the comprehensive breast care program. Each microsystem in this is color-coded. So there was a biopsy, and then meeting the breast care coordinator, Margie Cole, and an MRI, and an appointment in shared decision-making, a second MRI, meeting the surgeon, meeting the medical oncologist, etc. So this portrays 6 months of care, and you'll note that there were actually 2 instances of formal shared decision-making with many other smaller decisions along the way. If Amy were here or talking with you privately, she would tell you that this 6 months of her life, when she went in and out of these clinical microsystems, sometimes it was fantastic. Her first meeting with Dr. Pam Ely, phenomenal. Her care from the wig lady, fantastic. And some things were really dreadful. Turned out her first visit with her surgeon was a disaster. It got better, but the first visit was not good. She was going to have infusions, and so of course stat labs prior to infusions, chemo, is part of the routine, but on several occasions stat labs were not stat. It was hours of delay because the fill-in worker didn't know that a person like her required stat labs. Amy's done very well, and her story and her voice actually helped Dale and her colleagues get a better appreciation of the patient's experience and use this to improve the care program. So you can think about the quality and value of healthcare for people and for populations, clinical populations such as those that you're interested in, as requiring wonderful alignment between different layers of the system of healthcare. So that this is a picture that we often use. We can think of a macro system, Dartmouth Hitchcock. I guess my pointer is barely working. The macro system might be Dartmouth Hitchcock Health System, and within that, cancer services. We might think of a mesosystems, a collection of programs and clinical microsystems around a particular population. So the comprehensive breast care program would be a mesosystem. And then the front lines of care we call clinical microsystems. It's the sharp end. It's where people that we'll call patients meet healthcare professionals. So whenever a person goes beyond their capacity for self-care and they're in a relationship with a health professional, so I'm the patient, Dr. Vidal is my physician, we've just formed a clinical microsystem. It's about relationship and communication beyond self-care. And Amy, as you saw, was in and out of many different clinical microsystems, and the extent to which care within and between them is aligned and well done will determine the experience and the outcomes and the costs of everyone that enters the health system. So our key assumption, a great health system always gives patients everything they want and need, and only what they want and need, just when they need it and at the lowest cost. So that's an overall assumption that I'll make that we'll go with. So this is Amory Lovins. He's the founder and director of the Rocky Mountain Institute. He's a person not in healthcare, he's in energy and a global thinker on energy and environmental concerns. But he became a bit interested in healthcare, and he had this riddle: how is a kilowatt hour of electricity like a day in the hospital? Amory says no one wants either. What do people want? Hot showers, cold beer. Best health care, best care, lowest cost. And what Amory Lovins is reminding us of is that we should focus on what he calls the end user. We'll call them the patient or the person living in the community or the family that's the beneficiary of health care. And health care is only as good as it helps that individual or that family or that community. And so the point here is that high-performing health systems must provide high-value care to the end user, to the individual, to Amy. And how might we visualize this? So this is a model that we often use to create the physiology of a person moving into a clinical microsystem or into a healthcare system. So we start with an individual, it could be me or it could be Amy, with an initial health status and expectations of good care and hope for best outcomes. And we've had a cost meter running since birth, and that cost meter, our expenditures will continue to run. And then I enter into the comprehensive breast program, and I meet Margie Cole, and there's some orientation, and there's an initial workup and plan of care, and nothing that follows can be any better than this. This is the critical point that keeps being changed, and depending on our needs, acute care or chronic care or preventive care or palliative care or a combination. And right here, a lot of the magic happens with the decision making and hopefully the informed decision making that lights up the plan of care. So this is extremely obviously critical. And then we follow a person over time, and how am I or how is Amy doing? What are the health outcomes at 6 days, 6 weeks, 6 months, 6 years? What's my experience against my need for good outcomes and good experience and good quality? And what's the new costs that have taken place between time 1 and time 2? So it's an overview. And then if we, courtesy of Glenn Elwin and his colleagues, focus in on that critical instance or instances of decision making, we can view that as a process, just as a critical process in healthcare delivery. So viewing this as a process, shared decision making in clinical practice, a process of deliberation. So there's initial preference and construction of preferences and informed preference that's mediated by choice talk and option talk and decision talk and abetted by patient decision support. So we could see in Amy's case that if we had been following her and understanding her choices about full or partial breast surgery or what kind of chemotherapy to get, she would have been involved in choice talk, option talk, and decision talk and in the context of the Center for Shared Decision Making at Dartmouth, and in consultation with Dr. Ely and with Margie Cole and with staff like Kate Clay at the Center for Shared Decision Making. The point of health systems is to provide best health and lowest cost to the individual and the community, and this gets us to the idea of value. So we focus on value, and we might say that value for an individual or a population is a function of three things. It's a function of the person's outcomes that matter to them. Outcomes do matter most. It's a function of their care experience. Are they getting what they want and need when they want and need it? And it's a matter of cost. Cost to the individual. My health care expenditures, my time, so there are direct costs of receiving health care, expenditures by myself, by my insurance company, so direct costs of health care, and there are also indirect social costs. So Amy's a teacher. If she can't be teaching, there's a substitute teacher with her kids in her classroom. That's a cost to the community, an extra cost to the community. The town of Pomfret pays twice, besides the medical expenditures. Well, now let's focus in on experience. And what matters most, we know from focus groups and other work, from an individual point of view, can I get into the system when self-care fails me? Do I have access to the professional care system? Am I engaged in my own care in a way that makes sense to me? Am I knowledgeable? Am I active as I can be? Informed decision making. Do I know my options? Do I know my alternatives? How does my choice fit with what I understand is best and best for me? This requires great communication and coordination across all of those different parts of the system that come into play. So you could think of informed decision making as really being a precondition for good quality health care, a precondition for good value health care, because without it, everything else fails. The plan of care can't be correct. It's really the linchpin. So moving rapidly into consideration of measurement. And the rest of today, much of today and our next couple of days will be focused on measurement. And so there's process measures and outcome measures around informed decision making. And for me, with respect to process, very pragmatic. What works best, where, under what conditions, to provide the best informed choice that may be associated with the best outcomes. So what works best under what conditions for what type of person? Very critical to design and implementation and sustainability. And how can the best shared decision making practices be scaled up so that they can move across the Netherlands or across the UK or across Sweden or across Massachusetts? How can they be scaled up and embedded in all of those different little clinical microsystems that's at the sharp end of care, where the professionals meet the person that we'll call the patient? And then on the right-hand side, some categories of outcome measures that I'll just call decision quality. What's my knowledge of my alternatives? Am I ready to make a decision? Does the decision that I make fit my preferences? When I've constructed my preferences against good information and reflection, what's the match between my preferences and the decision that I make? So my preferences were considered in making this decision, and what we'll hear later in the conference, another very important take on this. Did the physician or doctor misdiagnose the patient's preferences on the road to providing treatment? So this was meant to be a quick panoramic view on health systems and people entering into them, and what we might think of as value and what we might think of as the measurement of value, and then a sharp focus on shared decision making. A few take-home points. People like you or me or Amy become patients when they make their journey in and out of the healthcare system. People want best value, best outcomes, best experience, lowest real cost to them. Engagement in informed decision-making and care planning and self-management are critical for best outcomes. It's a partnership between the individual and those that are there to serve the individual. And to the extent that that partnership is valid and works, we will get the best outcomes or something less than that. And finally, improving care for individual patients and for clinical populations requires measuring value. And a key facet of value measurement is to create and use valid metrics on the decision-making process, what works for which patients under what conditions, and on decision quality, knowledge of alternatives, readiness to decide, and choice fits preferences in the flow of care.